Well, good afternoon, everyone. Look, yesterday when I was giving this lecture, the recording malfunctioned, so I'm going to just try to give it again and see if it works this time. So there's a recording of the talk. I wanted to talk today about pediatric CT interpretation, and particularly about the interpretation of head CTs in children. And the reason to do that is because the reason to focus on head CTs is because many of the principles that are associated with the interpretation of head CTs in children, brain CTs, are transferable to CTs done of other organs, such as the chest or the abdomen, other regions of the body. You can use the same principles that we'll learn today, and also because head CTs are the most common indication or the most common type of CT done in children. So we'll go through that today, and yeah, we'll see. CTs are becoming much more widely available now in provincial hospitals, so it's worth us knowing about that. I think, though, that before, when people get CT scans, they may think it's replaces somehow the clinical process, but it doesn't. It really just augments the clinical process. And before you do a CT, you always need to have a question about the diagnosis that can't be identified or answered by all the other information you have, but is likely to be found on a CT. So, for example, a child who has fever and focal neurological signs could have a cerebral abscess, or they could have had a meningitis with a stroke, and those things may be answerable by a CT. A child with acute neurological deterioration and signs of raised intracranial pressure who's afebrile might have a cerebral tumour, and that can be answered by a CT. Hydrocephalus, for example, can often be detected clinically, at least in infants, or an ultrasound. And so for that, you don't need a CT. A tuberculoma in a child who's got other features of TB, central nervous system TB, and has focal neurological deficits, might have a tuberculoma or might have an area of cerebritis leading to a stroke. That can be identified on a CT. It's not usually useful in long-standing neurological conditions. A CT, for example, for children who've got a good story of cerebral palsy, if you can get the history of cerebral palsy from an early age of delayed development, delayed motor development, progressively through infancy and young childhood, that's enough usually to make a diagnosis of cerebral palsy if the neurological features are there. Although we often do CTs for children who, for example, have chronic neurological conditions, they rarely change management. And so I think we should not be doing CTs unnecessarily. One, because it's radiation risk, and two, because it's logistically often difficult and expensive and costs the family money. So use it for the right indications, which is to answer a clinical question that you can't find the answer to by the neurological process. As I said, it augments the clinical neurological examination, by the end of the neurological examination, you should know where the lesion is likely to be and be able to speculate based on the history and the examination findings what the lesion could be. It could be infective, it could be tumor or something like that. And then doing a CT can be a useful thing. So always have a clinical question for a CT. Radiologists who have to report CTs want you to come with a clear clinical question, and always have a hypothesis based on the history and the clinical examination and other tests that enable you to make an assessment of where the lesion is likely to be and what it might be. And then you can do a CT to find out if that is supported, if your clinical suspicion is supported by a CT scan. The CT confirms the answer to the clinical question or the hypothesis, and then you use deductive reasoning to put all of that information together to make a diagnosis or to assess other things like the prognosis of the patient, etc. So let's go through some some important aspects of reading a CT, and as I said, that it is transferable to other regions of the body that you might do a CT. Firstly, you need to know what projection the CT is. This is a horizontal projection, but there's also the sagittal projection and there's the coronal projection. I'll show you some of those. Sagittal is cut down the middle, and a coronal projection is cut cut that way. Sorry, cut that way, and if I try to explain CTs to parents when I'm showing them the CT, it's like as if you could put slices through the brain and then take the top off and then do a photograph, a black and white photograph of what is there. So firstly, you need to know the projection. Secondly, you need to know the level at which the images the image you're looking at has been taken. Of course, when you scroll through, you get all the different levels in that projection, but you need to know what you're actually looking at. So this, for example, is a horizontal CT that cuts through the frontal lobes, the parietal lobes here, the parietal lobes here, the occipital lobes posteriorly. You can't, for example, it's not low enough to see the cerebellum or the base of skull, or the temporal lobes, for example, and you see the ventricles in a certain again at a certain level. At different levels, there are of different sizes and a different shape. So need to know the level through which the CT image is being done. You need to know the projection, whether it's horizontal, sagittal, or coronal. You then look at what's called the grey-white differentiation of the brain. This is a brain looking at a brain CT, and the grey-white differentiation refers to the transition between the grey matter, which is at the periphery of the brain, which mostly contains astrocytes, cell bodies, neuronal cell bodies, and the white matter, which is the deeper parts of the brain below the peripheral cortex, and that mostly contains axons, and it's called white matter, even though actually on a CT it's darker than the periphery. You can see the periphery, the grey matter, is actually a lighter colour than the deeper structures, and that relates to density. And when the density of the peripheral parts of the brain are of higher density because they are neuronal astrocytes, cell bodies all packed together, and the lower density, the hypodense regions, the darker regions, because it's mostly axons. The reason why they're called grey and white matter has nothing to do with the CT. It's historical, and it's based on when you do a cut section through the histological part of the brain. If you cut the brain, then the white matter is the deeper structures, and it's called white matter because the axons are covered in myelin, which is a fat, and that looks white when you just look at it macroscopically, a cut section of the brain. Whereas the peripheral cortex, which is more packed with cell bodies, is grey in color. So that's the origin of grey-white differentiation, and it's just inverse on a CT projection. The grey part is the grey matter is a little bit lighter. But what you can see on a CT, if we get over that color paradox, if you like, what you can see on a CT is that there's grey-white differentiation. That is, you can see the difference between grey and white. I'll show you some CTs where there's no difference between the grey and the white, where it's all dark, and that's where you've lost grey-white differentiation, and that's typical of a child who has diffuse cerebral edema. So that's great. So you need to look at the projection. You need to look at the level through which the CT is done. Look to see whether there's normal or abnormal grey-white differentiation. Look at the sulcal and the gyral pattern. The sulci are the gaps in the brain, right? The gaps between the convolutions of the cerebral cortex, and the gaps just contain cerebrospinal fluid. And so the cerebrospinal fluid is black, as are the ventricles, right? So you need to look at the ventricles. As I said, the ventricles look different at different levels of the CT, the CT, and obviously different. They look different shape in different projections, but they should be quite black, right? Hypodense, extremely hypodense. I'll get onto the density issues in a moment. So you're looking at the ventricles, the ventricular size. Then you should be looking for whether there's symmetry or asymmetry of all the structures and all the densities. So is the symmetry of grey-white differentiation, does it look the same, roughly the same on both sides? Is the symmetry of the ventricles? I mean, sometimes you get asymmetry because the patient's head is slightly tilted in the CT scanner. And if that's the case, then one ventricle will look larger than the other in a different projection. And you just need to be sort of understanding that, whether or not there's an artifact of the head tilt in the CT scanner. It's the skill of the radiographer that they hold the head, or the head is kept in the midline, so they get a very symmetrical CT scan. Then the other thing, a fundamental thing, is to know your left from your right when you're reading a CT scan. I always think about it like a chest X-ray. The left is the projection on the left. So the left side of the brain is the same as the left side of a chest X-ray, and the right side is the right side. So just, it's a convention. You just need to know that. And lastly, look for any focal lesions. So a focal lesion will give asymmetry, of course. If you've got a focal lesion which is only in one part of the brain, in one lobe or in one hemisphere, then that will lead to the appearance of asymmetry. So you're looking for the same thing, but that's what you look for. All right, move on. So what I showed you was a normal CT scan. This is a normal child CT scan of a 6 or 8 year old child, and you can see that there's normal grey-white differentiation. There is a sulcal and gyral pattern, isn't it? You can see the sulci there. It's not completely, completely full. There is some sulcal and gyral pattern, and you need to scroll through all levels to appreciate the extent of the sulcal and gyral pattern. This is a CT scan, also normal, of a slightly younger child who has a bit more space around the brain. You can see there's more cerebrospinal fluid around the frontal lobes, and the ventricles look a little bit larger. This is at a different level. You can see clearly the sulcal and gyral pattern. It's a bit harder to see the grey-white differentiation, and that probably relates as much to the quality of the image as what it does. It's still a normal CT scan. This is a normal head CT scan of a young child, and for which there's symmetry of the ventricles, even allowing a little bit for some tilting of the head, etc. Yeah. Okay. Now, I wanted to discuss density, because a CT scan is a spectrum between black and white, and there's no other colors. Everything is on that spectrum, and the spectrum is there is a way of measuring the spectrum. Structures, all structures are on that spectrum, somewhere between black and white. Structures that are very dense, such as bone and blood, fresh blood, they are white. And structures that are very hypodense, very low density, are black. So air, for example, surrounding the brain, and water, which is the same as cerebrospinal fluid or subarachnoid fluid, that's very low density. You notice the lowest density is air, and the cerebrospinal fluid is still a little bit, has some little grey flecks in it, and that suggests that it's not as low a density as air, which is not surprising. Water is not as low a density as air. So you need to get used to that spectrum between hyperdense structures and hypodense structures. Hyperdense meaning very dense, and hypodense meaning not at all dense. The white structures are hyperdense. And as I said, there's a spectrum and a numerical spectrum on which you can measure this. And they're called Hounsfield units. And I want you to appreciate what Hounsfield units are. Anything that's very, very dense, so bone or fresh blood, has very high Hounsfield units. And they're hyperdense. So bone has Hounsfield units that are well above 1,000. Fresh blood often is the same, around about 1,000. Calcium deposition, also if you've got calcium deposited in the brain, for example, in children who've got some intrauterine infections, such as toxoplasmosis or congenital CMV, they'll often have calcium deposits within the brain. Children that have the parasitic infection neurocysticercosis will often have little small lesions in the brain that have calcium deposits in them, and they will be very hyperdense, small micro lesions. If a child's had previous bleeding within the brain, that sometimes becomes calcified over a long period of time, and that might lead to hyperdensity. When you've got blood, when you've got fresh blood that is hyperdense, it has high Hounsfield units, it's white in color. After a period of time, the blood liquefies, it becomes more like water, and then it changes from being white to being grey, and then being a darker color, a darker grey. And that depends on the content of water. So when you're looking at to see whether there's blood within the brain or around the brain, then you can roughly, not accurately, but roughly time the timing of the bleeding to the density of the blood clot that's there. So fresh blood is white, older blood is grey, and it usually transitions around about sort of 7 to 10 days where it goes where the blood liquefies. Anything that's very black has very low Hounsfield units, or sometimes they can be negative, so even less than 0, so minus 20 or up to 20. And so water, for example, so cerebrospinal fluid in the ventricles, or the normal cerebrospinal fluid in the subdural space or the subarachnoid space, or the sulci that are between the convolutions, the gyral pattern of the brain, they will be that's very low density. It has very low Hounsfield units. Water within the brain, so cerebral edema, also has low density, and the brain then becomes changes from being the normal grey-white differentiation to being more dark in color, and that's just because of water accumulation. So the more water there is, the darker the brain looks. So when you've got widespread diffuse cerebral edema, the brain will look very black, and it'll look swollen, and you'll have lost the sulcal and gyral pattern of the brain, and you'll have lost the grey-white differentiation that's normal. Other areas that are also black are where you've got a lack of blood flow. Anything where you've got high blood flow, a density of blood vessels, that'll be lighter in color or whiter, and anything where there's lack of blood flow, there'll be ischemia, so it's lower density, and that is partly because of the lack of blood flow, and it's partly because of the edema that surrounds any area of stroke or ischemia. As I said, old blood, when it liquefies after 7 to 14 days, becomes darker in color, and so the Hounsfield units drop. So that, I think that's important when you're looking at a CT scan, to understand the colors on a CT scan are anything from black to white, but and you can understand the water content and the density of those structures based on that color spectrum. Right. So I showed you some normal CT scans before, and I just wanted to show you, this is a child who's had a subarachnoid hemorrhage, quite a large subarachnoid hemorrhage. And what you can see is that there's a whiteness around the midline of the brain is the falx, and you can say, well, the level of this CT scan is quite superior. You can't see it's not looking at the frontal lobes and the parietal lobes and the occipital lobes. It's really just looking at the top part of the brain. The parietal lobes only at the apex of the brain, but you can see that there's bleeding along the falx cerebri, which is the tissue that separates the cerebral hemispheres, and the blood isn't as dense as the bone, but it is quite white, isn't it? It's not fresh white like bone, not as dense as bone, but you can tell that's blood. And there's also blood surrounding the brain, right? So along the falx and surrounding the brain. And when you look at this, I'll just show you this one. When you look at this is the sagittal section, you can see that there's blood surrounding the brain here. It looks like of about the same age. Sometimes we see some blood that some looks fresh and some looks a bit grayer, and then you can wonder whether or not there's been the child's had two bleeds, two cerebral bleeds, or two extra axial intracranial bleeds at different ages. But here it all looks a similar sort of density. So there's subarachnoid hemorrhage, which is spread in the subarachnoid space and along the falx and along the subcortical region. And down into the posterior fossa. And you can see that the rest of the brain looks a bit darker, doesn't it? You can't see grey-white differentiation here, and that's because there is edema that is related to the hemorrhage. And so the brain, instead of looking like the normal convolutions of the brain, it looks rather blacker. I just want to go through how the brain changes with age and how the CT scan changes. These are three CT scans of children at different ages and different levels. So they're all horizontal projections, but they're at different levels. And in the first 2 years of life, the brain has maximum growth, and that's because you increase the number of cell bodies, so this number of neurons increase, and also there's myelination of the white matter. So the volume of the brain, the mass, the weight of the brain increases very substantially. And so there's less room for cerebrospinal fluid surrounding the brain. And these are three normal CT scans. So you can see in a neonate, there's more, you can easily see the convolutions of the brain. You can easily see the sulcal and the gyral pattern. You can easily see the ventricles, and at the base of the brain there's plenty of space. And that's because, and the cortex looks rather thin surrounding those structures. The cerebral cortex looks a bit thinner, and that's just because this is a normal neonate. It hasn't started that maximum brain growth. This is by 12 months of age, the child has much more brain volume. You can still see the grey-white differentiation. You can still see the sulcal and the gyral pattern. You can still see the ventricular system quite easily, but there's less space around the brain. Then as the child ages, so as I said, the maximum brain growth is in the first 2 years. After that, it slows down a bit, but there's still brain growth. The head is larger in this case, and you can still see the sulcal and gyral pattern. The grey-white differentiation is well preserved. The ventricular system is still the ventricles are still open, and you can see them quite clearly. And the CT scan of an older child or an adolescent or a young adult looks like this, looks relatively full like this. As a person ages, so beyond 60, then they start to have some brain atrophy. That's normal with age, beyond 60 or 70 years of age. And so if you do CT scans on elderly people, they look a bit more like neonatal brains sometimes, where you've got some loss of the brain volume. The other group of patients for whom even older children will have an appearance a bit more like a neonate are children that we have who have chronic diseases, and especially chronic malnutrition or, for example, disseminated tuberculosis. They will often have any form of a chronic illness where there's often also malnutrition as well. That will lead to a shrinkage of the brain, and they appear to have more space around the brain. There's some children that when with tuberculosis, we think they've got hydrocephalus, but actually it's just that their brain is generally a bit shrunken with the appearance of more space. It's not that their ventricles are under pressure or they're high. Often it is in TB, of course, but sometimes there's what we call sort of ventriculomegaly ex vacuo, which just means that the brain itself is shrunk, so the ventricles are a little bit larger. And that certainly occurs in children who've got malnutrition. The good news is that if you treat those conditions, if you treat their malnutrition, if you get them catch-up growth and their body grows, then their brain can grow. But it does account for why children who have severe malnutrition will have brains that look a bit more shrunken, and also they will have arrested development. They'll have delayed development, partly because of their motor dysfunction, etc., for their muscle weakness, but also partly because they've got impaired brain growth because they've got severe malnutrition. We also see that in other children with other chronic illnesses. So if you do CT scans on children who've got chronic cardiac disease, for example, they will often have relatively shrunken brains, which again you can get back to a normal stage of brain growth if those things are corrected and if the nutritional state improves. Okay, I've talked a bit about cerebral edema, and I just want to make the point that cerebral edema is more common in children than in adults, and it can occur for many reasons. It's essentially, it occurs because of three pathophysiological reasons. One is when you've got some sort of trauma to the brain, there's a disruption of cerebral autoregulation. Cerebral autoregulation means that regardless of the blood pressure that we have, whether we're hypertensive or hypotensive, usually the brain blood flow is the same. The brain blood flow is more dependent on the metabolic requirements of the brain, so therefore it's not so dependent on our blood pressure. But when you've got a brain injury, then there's disruption of that cerebral autoregulation. So a high blood pressure gives you a high brain blood flow, and a low blood pressure reduces the cerebral blood flow. There's also, because of an injury, there's a disruption of the blood-brain barrier, which is normally less permeable than the rest of the body, and fluid can leak out of the blood vessels into the brain tissue. And also because of an injury, whether it's traumatic brain injury, contusion, a hemorrhage, a tumor, asphyxia, hypoxia, that can lead to cellular death, and it can lead to swelling of those cells. So if the cell membranes are damaged, then the cells accumulate water and you get what's called cytotoxic edema. So it can be vasogenic or vasogenic, meaning related to the blood-brain barrier, or it can be cytotoxic, meaning it's related to cell death. But essentially on a CT scan, it looks just blacker. And you can have it with trauma or meningitis or encephalitis or hypoxia or ischemia. They're the most common things. So if a child's had an arrest, if they've had an asphyxial event, whether it's perinatal asphyxia, like with birth asphyxia, or later on they've had choking or drowning, then they may have cerebral edema. So this is just a case, a 7-month-old boy who presented with, the true story, presented with lethargy, vomiting, and seizures for 2 hours. He was poorly conscious and he was a bit hypoxic, so oxygen saturation of 88% in room air. He had dusky lips when he presented. he had a high fever, he had tachycardia, and he had cold hands and feet. He looked like he was in a shocked state, and he had streptococcus pneumonia on blood cultures. And so this is very likely to be pneumococcal meningitis. In fact, that's what this boy had, pneumococcal meningitis. And I show you this CT scan because what it shows is the features of cerebral edema. There is a loss of grey-white differentiation. You can't tell the difference between the peripheral grey matter and the white matter internally in the subcortical region. It looks all grey, doesn't it? All throughout, dark grey. And you can't see the ventricles in this projection. There's a little bit of space between the temporal lobe and the frontal lobe, but it's not at all clear. So there's less space. It's a swollen brain. There's a loss of grey-white differentiation. And this is pneumococcal, what we call pneumococcal cerebritis, where there's a diffuse inflammation of the brain, which can occur, especially in young infants who've got pneumococcal meningitis. So it's not just an inflammation of the meninges or the coverings of the brain, it can be an inflammation of the whole brain. This is another child who had a hypoxic injury, and you can see this is also diffuse white cerebral edema involving all parts of his brain. There is no, you can hardly see the ventricles. There's no sulcal and gyral pattern. There's a loss of grey-white differentiation, and there's no space around this brain. So this is a brain that's under considerable pressure. Sometimes you can have not widespread global cerebral edema, but focal edema. You can have edema surrounding, for example, a hemorrhage or edema surrounding a tumor. And I'll show you some pictures of that, some images. You can see that as a darker part because there's cerebral edema meaning water accumulation, and there's more water in the brain than there is normally in brain substance in that area. So I showed you before a subarachnoid hemorrhage, and I just wanted to show you some other forms of hemorrhage. This is a child who had a traumatic brain injury, a 6-year-old boy who had a traumatic brain injury. You can see the large subcutaneous hematoma on his forehead, on his occiput. So frontal lobes, parietal lobes, occipital lobes, so that in the parieto-occipital region, he's got a large hematoma. There is also blood not in the brain substance, but surrounding the brain. And this is a large subdural collection of blood. This was from a traumatic brain injury. Sometimes when you've got a large subdural or an extradural collection of blood, you will see the brain underneath being edematous, especially in a focal region. This is not too edematous, so you would imagine, looking at this, that if the neurosurgeons were able to drain that and remove the clot, then the brain would probably spring back to life and have more space. You can also see from this scan, there's a bit of what we call midline shift. The falx is not entirely in the midline, but the ventricles look pushed over to the right side a bit from this left-sided subdural hematoma. So again, this is a brain that's under some pressure, some pressure related to the subdural hematoma. Now, I said there's a difference between extradural and subdural hematoma. A subdural hematoma looks a bit more convex in nature, whereas an extradural hematoma looks more like this. So these are two extradural hematomas that the one on the left-hand side is a 9-month-old child who had an injury to the middle meningeal artery and got a large extradural hematoma. Again, the brain is under pressure, as in the ventricle is narrowed on the right-hand side and it's normal size on the left side. You can see that the brain is very compressed. There's substantial midline shift of this large extradural hematoma. An extradural hematoma is concave in nature, whereas a subdural hematoma is a bit more convex. Sometimes it sort of layers all along the subdural space. The CT scan on the right-hand side shows a large right frontal extradural hematoma. And this was a child who had a traumatic, in fact, penetrating injury to the frontal lobe. And you can see that it's penetrating because within the large blood clot that's there, the large extradural blood clot, you can see some black areas, and the black areas are air. And so if you've got air within the brain substance, then extremely hypodense, and it's not just water, is it? It looks more like the air surrounding the brain. Then you know that there's been some penetration. So this is a large traumatic penetrating extradural hematoma. And also you can see the midline shift. The structures are quite distorted. And the brain is under pressure. You can't see the normal sulcal and gyral pattern. There's not a lot of cerebral edema there. There is a bit surrounding the extradural hematoma, as you could imagine. It will be there. But typically, if this is removed, then the brain will be preserved adequately. So we've talked about extraaxial bleeding, that is subdural hematomas and extradural hematomas. Sometimes you get bleeding within the brain itself. And in this scan, it's at again, horizontal projection at a low level, because what you can see is the temporal lobes here, the grey parts laterally are the temporal lobes, and these are the frontal lobes coming into view. Right, so just above the sinuses. These are the nasal sinuses, and it's above the sinuses. You can just see the frontal lobes. And this here is posteriorly is the lower part of the cerebellum and the upper part of the brainstem. And what you can see is that it doesn't look grey. It should be the same colour as this, as the temporal lobes, but it's not. It's quite white. So this child has had a brainstem hemorrhage, or a hemorrhage that's involved the posterior fossa posteriorly, that's led to a tracking of blood down into the brainstem. So a very serious hemorrhage in a child. Yeah. Sometimes a hemorrhage can occur because of a traumatic injury, and sometimes it can occur because of an AV malformation. That is a collection of blood vessels inside the brain that just suddenly start to bleed. That typically occurs, AV malformations typically occur in children around about just before and around puberty, so around 10 to 14 years of age. And sometimes hemorrhage can occur into an existing lesion. And it's quite hard sometimes to identify that, but it just looks, these are two hemorrhages that have occurred into cerebral tumours. So the child might have some chronic headaches, and then they suddenly become unwell with a severe headache, with vomiting, decreased conscious state. And that's sometimes because they've had a bleed into a cerebral tumour. So the one on the left, this is again, it's a horizontal projection. You can see the eyes there, you can see the sinuses, you can see the temporal lobes. This is the cerebellum. So this is a large posterior fossa tumour into which there's been a recent bleed, and you can see the blood there, and that's why that child became acutely severely unwell and unconscious. And this on the right hand side, you can see this large left-sided cerebral hemorrhage, but it just looks unusual for a hemorrhage, doesn't it? Because there's a darker area inside it. And I think this is where there's a tumor sitting here, there's edema surrounding the hemorrhage, and there's some blood. You can see the tumor has bled. And again, there's compression of the left lateral ventricle, but not to the point there where there's widespread cerebral edema. There is focal cerebral edema surrounding the hemorrhage, which is within a brain tumor. So when you're doing a scan, it's important to know whether contrast has been given or not given. And the reason for that is that anything that's white in the absence of contrast, is likely to be blood. Or whereas if you've got no abnormal whiteness or hyperdensity within the brain in the absence of contrast. And then there is a focal abnormal hyperdensity with contrast. Then it suggests that there's not a hemorrhage, but there's high vascularity, because there are blood vessels that are being highlighted by the injection of contrast. And so this is a situation where these are both contrast enhanced CT scans, and this is in a child who's got TB meningitis, so tuberculosis meningitis. And you can see several things from this. One, contrast has been given, and you can see the area here in the left parietal lobe that's quite outlined. It's a contrast enhancing lesion in the left parietal lobe. These are the same patients, just different projections of the CT, and you can see that the ventricles look a bit large, don't they? They don't look normal shape, normal size. And this is a child who had TB meningitis, and a contrast enhanced CT scan highlighted these areas of hypervascularity. And so often you see that when a child's got severe inflammation, or they've got a cerebral abscess with a capsule around it that is vascular and lights up with lights up with contrast. So as I said, this is TB meningitis. The other areas of white in this, again, sometimes people overinterpret this. These are the choroid plexus that produces CSF. They're a bit calcified, so they produce cerebrospinal fluid, and that's a normal finding, just the choroid plexus being white like this. And the falx, this is a contrast enhanced image of the falx cerebri, which is the membrane that separates the hemispheres. And that, if you saw the non-contrast CT scan of this, it wouldn't look nearly as bright, but there's lots of blood vessels along the falx normally, so that will often light up as white. But the abnormality is the asymmetry in this scan, and you can see that there's a asymmetrical lesion in the left parietal lobe, which is enhanced with contrast. This is an example of a cerebral abscess, and as I said, this was a 10-year-old boy who presented with headaches and facial pain. He had very severe forehead and cheek pain. And this is a cerebral abscess related to severe sinusitis. Cerebral abscesses commonly occur in the frontal lobes, and the way you can tell it's likely to be an abscess, it's ring enhancing. All right, it looks encapsulated. It's dark in the middle, so there's more fluid or pus, and surrounding it is an enhancing capsule, as in when the contrast has been given, that enhances with contrast, and then surrounding all of that is oedema. You can see how the surrounding area surrounding the abscess is much darker than the rest of the brain. So there's increased water in the brain there, and there's surrounding the cerebral abscess. That's a typical cerebral abscess. You also can't see the left lateral ventricle here. It's been obliterated by the cerebral abscess. You can see the right lateral ventricle, but not the left one. Again, this is an example of focal cerebral edema, and cerebral edema can be very focal, as in surrounding a lesion, a traumatic lesion, an abscess, a tumor. It can be regional. It could involve, for example, a whole lobe, so the frontal lobe, or it could be hemispheric, so involve an entire hemisphere, or it can be global, involving the entire brain. And so to look for where the edema is, you need to look at what's normal about the CT scan too. So there are some normal parts of the brain where you can see the normal grey-white differentiation and the sulcal and the gyral patterns of the brain, which looks relatively normal. And the abnormality is a focal area of cerebral edema surrounding a cerebral abscess, which is contrast enhancing. In fact, it's at least bilobed. It might even be a trilobed abscess. You can see one abscess there, another one there, another one internally, and maybe another one here. So the abscess is quite large, I would say. Okay. I just wanted to get back to, always needing to have an indication for a CT, and that is informed by the history and the examination, after which you should be able to speculate, well, where is the lesion likely to be if the child's got a focal deficit on the left left hemiparesis, then the lesion is likely to be on the right cerebral cortex. It'd be worthwhile looking at the lecture on neurological examination to find out what the steps leading up to a CT can be, but at least to try to understand where is the lesion likely to be in a child with a neurological problem, and what the lesion is likely to be based on the history and the examination is always necessary before you do a CT scan. But a CT scan can be very informative in these situations that I've shown you, with a possible cerebral abscess, a cerebral tumor, sometimes in hydrocephalus to see whether there's some obstruction or not. Often if you're looking for a tuberculoma, a stroke, venous sinus thrombosis, there's many reasons why a CT scan can be useful. As I said, it's not usually useful in long-standing neurological conditions like cerebral palsy, because we can make the diagnosis without that. Although we often do CT scans, they rarely change management in the situation of a chronic neurological problem in a child. So again, the history is the most important part, the history of how long the child's been not developing well, or been losing their milestones, or has been neurologically abnormal, or having seizures, whatever. The history of the duration becomes very important. I talked a bit about contrast, but it is important to decide whether you're going to give contrast in a certain CT or not. In trauma, you don't need to give contrast, or it's very rare that you need to give contrast, because it's usually better to do a quick CT, quick fine cut CT, because that will identify blood within the brain or surrounding the brain, an extradural or a subdural or intracerebral blood. It'll identify fractures. It'll identify cerebral contusions, which just look like more bruising of the brain or blood, or it looks more like increased water, a darker color. A non-contrast scan will identify edema, and it enables a rapid assessment in traumatic brain injury. You rarely need to give contrast. The only reasons I give contrast in trauma is if I'm suspecting a child's got a venous sinus thrombosis. And sometimes if you've got blood vessel damage, then you can have a venous sinus thrombosis, and that can only be shown up in with contrast. But usually in trauma, just run the patient through the CT scanner and don't do it. However, if you want to explore whether there's a vascular lesion like an AV malformation or a tumor or an encapsulated abscess, or look at the venous sinuses, then contrast needs to be given. So a tuberculoma, I'd usually give contrast. So that's where you need to know what the question is before you can decide should the CT be done with and without contrast, with or without contrast, or then when in a contrast enhanced CT scan, you always run the patients through before the contrast, see the non-contrast images, and then give contrast. But again, you don't need to give it all the time. And the reason why it's good not to give it in certain circumstances is because it's not benign. Rarely, very rarely, patients can have reactions to contrast. It's an iodine-based, Omnipaque is iodine-based. You can have rare reactions to it, which can involve vomiting or even anaphylactoid reactions. Anaphylaxis to contrast can occur. And also in patients who've got impaired renal function, if they've got kidney failure, then it certainly can make the renal function worse. If a child's got only mild renal impairment, then you can usually avoid it by hyperhydrating the patient beforehand and having them on some diuretics, so you make sure that they keep passing urine and excrete the contrast. But in patients with well-established renal failure, you will make their kidney failure worse. Again, these are extreme circumstances, and usually you can give contrast quite safely when you're doing a CT scan, but decide whether you need to give it or not. In traumatic brain injury, usually not. In all other forms, looking for tumours, looking for abscess, looking for strokes, then I usually give contrast. Okay. All right. Well, that's all I wanted to say today. I hope that's been useful. It's just the basics of CT heads, and as I say, I hope that most of that is transferable to CT of other regions, the chest and the abdomen. I'll stop there. There were some questions yesterday, but I'll stop there, and I hope that's been useful. At some other time, we'll talk about abdominal and chest CTs, but I hope that's been useful. Thanks everyone for your attention today.